Today we will discuss regarding myelitis and autoimmune myelopathies. Myelitis. Inflammation of the spinal cord is called as myelitis. It can result from infections, immune-mediated or any other causes. And myelopathy is a neurological disorder localized to the spinal cord. Myelitis is the inflammation. The length of T2 hyperintense lesion of the sagittal spinal cord is very useful, particularly if it is less than 3, then MS, and more than 3, it is associated with NMO spectrum disorder. Because of neuronal antibodies and better radiographic characterization, it helps in diagnosis of myelopathy. So what are the differential diagnoses of immune myelopathies? It includes non-inflammatory myelopathies like compressive, vascular, neoplastic, metabolic, nutritional, infectious, toxic, and inherited. We'll mainly focus on immune myelopathies in this lecture. So what is the epidemiology? It is more common in females, can affect all ages. In children, MOG myelitis is associated with edema in 50% of the cases. So it is very important. An enterovirus associated flaccid myelitis can also occur in children. In elderly, particularly in the males with lung carcinoma and females with breast carcinoma, paraneoplastic myelopathy can occur. And dural fistula, particularly in an elderly male with thoracic myelopathy, it can be associated. We'll talk in 10 points regarding immune myelopathies. So first is time to nadir. Time from onset to maximum neurological deficit. It helps in evaluation. Hyperacute is less than 12 hours. So most common is spinal cord infection. Vascular etiology. Second is acute or subacute. That is idiopathic or disease associated or immune in this category. And chronic progressive, it could be spondylotic, it could be dural fistula vascular, it could be metabolic, it could be paraneoplastic, neoplasm, or primary progressive MS. It is beyond 21 days. So less than 12 hours, less than half the day, 1 to 21 days, and beyond 21 days. 3 types according to time to nadir, to maximum weakness. So according to the time core, what are the differential diagnoses of myelopathies that we will discuss? So if it is acute, that is in less than 12 hours. So most common, most important is vascular. You must rule out spinal cord infarct, whether there is any vascular risk factor you should evaluate, whether it increases with Valsalva or there's a disc adjacent to lesions. You should also rule out hematoma or a fibrocartilaginous embolism. Trauma, if there's a background of a surface myelopathy to be ruled out, spinal cord contusion with recent trauma. If it is subacute, first is inflammatory demyelinating, multiple sclerosis, NMO spectrum disorder, myelin oligodendrocyte glycoprotein, edema. So all are important subacute inflammatory demyelinating myelopathies. In MS, it is associated with short peripheral T2 lesions in the dorsal and lateral columns. NMO associated with LETM more than 3 segments. MOG could be long or short. Conus is very characteristic and non-enhancing. And in edema, there can be a coexisting deep gray brain lesion. Other inflammatory like sarcoidosis, here the characteristic thing is that milder deficit despite large lesion. Lesion can be large, but the deficit is very mild and there is a linear dorsal subpial trident enhancement. Other connective tissue disorders like Veche, SLE, Sjogren can cause paraneoplastic etiology. If there is a known case of carcinoma, there are risk factors, or there are tract specific lesion you must rule out, and immune checkpoint inhibitors. Chronic progressive dural fistula, cavernous valve formation. Dural fistula, you must look for flow voids, clinical worsening after exertion or after steroids, or thoracic longitudinal enhancing lesion. Dural fistula. Cavernous malformation, you look for popcorn appearance. Other inflammatory, progressive solitary sclerosis, primary progressive multiple sclerosis, spinal cord sarcoidosis, paraneoplastic. And other infectious like syphilis, TB, epidural abscess, viral, HTLV, and HIV. In spondylotic, there is a history of neck trauma or neck osteoarthritis. And other chronic progressive, there could be neoplastic, like a glioma or a lymphoma or a metastasis. So in the glioma, there's a CAP sign and other hereditary. Adrenomyeloneuropathy, hereditary spastic paraplegia, mitochondrial disorders, other genetic. So in HSP, there's a spasticity is disproportionate to weakness. Toxic metabolic, we'll discuss. Nutritional deficiency, B12, copper. Look for history of any bypass on any supplements, malabsorption, and toxic intrathecal methotrexate or B6. Toxic exposure is must to be ruled out. And iatrogenic bioradiation, radiotherapy. So this was regarding time to nadir and differential diagnosis of immune myelopathies. Second, we'll discuss regarding the presenting features. So what are the presenting features? There's a development of the sensory motor deficit in one or more of the lower limbs. Mainly, it could be in the upper limbs also if it is high cervical. There is ascending numbness, often accompanied by a sensory level across the trunk that is characteristic. It could be autonomic dysfunction, and neurologic bladder, urinary retention, neurogenic ball, and sexual dysfunction. So, if there's a demyelinating etiology, there is a characteristic phenomenon that you must remember. First is a Lermit phenomenon, that is a electrical sensation that radiates down the spine and to the extremities on neck flexion, also known as Barber chair sign. Second is Uthoff phenomenon. There is a transient worsening of neurological symptoms from excessive heat. That is Uthoff phenomenon. Classically, both are associated with multiple sclerosis and a demyelinating etiology. Tonic spasm, frequently seen in anemospectrum disorders, the recurrent short-lived episodes of involuntary painful contraction, 30 seconds to few minutes. So on examination, there is a sensory level across the trunk, upper motor neuron pattern of weakness, may take time to develop. What is a McArdle sign? This is a rapidly reversible pyramidal weakness induced by neck flexion, MS myelitis, spinal shock in acute spinal cord syndrome. So these are the findings on examination. So what are the demyelinating disease that we need to discuss? This is the spectrum. One is MS, NMOSD, MOGAD, EDEM, GFAP, and CRMP5. So neuroimaging, fourth point to be discussed. So MRI with or without gadolinium imaging is modality of choice. If contraindication, you can use CT myelography if there is contraindication or MRI. Diffusion weighted imaging, in particular in hyperacute and acute myelopathy, is important. If there is persistent enhancement beyond 3 months, there is a strong consideration for non-inflammatory etiologies like a neoplastic or a dural AV fistula. So you must think of a neoplastic or a dural AV fistula when there is a persistent enhancement beyond 3 months, beyond 90 days. So few points regarding MS myelitis, extremely important and relevant points only that we'll discuss. So MS myelitis is a short lesion, not a long lesion, short lesion. It's a wedge-shaped lesion on axial images and involves the periphery of the cord in either the lateral or dorsal column. The spinal cord edema in acute phase can be seen in multiple sclerosis. It's a wedge-shaped lesion on axial. In axial, there's a wedge shape and it involves the periphery. It could be in the lateral column or the dorsal column. The edema is in acute phase. Enhancement in most acute lesions, it could be homogeneous or patchy, and ring enhancement in 1/3. True LETM is a red flag for multiple sclerosis. If there's a multiple sclerosis, true LETM is a red flag. So what are the main important points? One is a short lesion, wedge-shaped, lateral dorsal column. True LETM is a red flag, and edema can be seen in the acute phase. Here you can see the lesions, the wedge-shaped lesions in the lateral or the dorsal is a short lesion in the periphery, not involving the whole transverse section. So what you should know regarding anemomyelitis. It's an isolated longitudinally extensive T2 hyperintense lesion. It is isolated, usually single. It's a longitudinally extensive lesion but single. So in MOG, it is a double or multiple longitudinally extensive lesion. So it's the most common cause of both recurrent LETM and monophasic LETM, both anemomyelitis, myelitis optica. There's a pockets of signal intensity, so known as bright spotty lesion similar to the CSF, and contrast enhancement usually is patchy. In MS, it was a homogeneous or a patchy enhancement. Here it is always patchy. A ring-like enhancement and symmetrical central gray matter with extensive cord edema and short lesions in 15%. In NMO also, short lesions can be seen in 15%. So what is the key point in NMO? Key point in NMO is that NMO S3, it can coexist with systemic autoimmune diseases like SLE, Sjogren's, or EPLA. And testing for ECWA for in IgG, if positive, confirms a coexisting autoimmune neurological disorder rather than a neurologic manifestation of a systemic connective tissue disorder. Okay, so what does it mean if it comes positive and there's autoimmune neurological disorder associated? So it confirms that there's a coexistence of both, not a neurological manifestation of a systemic connective tissue disorder. Now, what you should know regarding MOG, it's a frequently LETM or multifocal rather than solitary. Conus involvement is characteristic. MOG, conus. Central, gray matter, so H pattern you should remember. Sagittal, T2 hyperintense line. Here you can see the H pattern and the T2 hyperintense line. Here you can see. And Gado enhancement less frequent. Here you can see the T2 hyperintense line. There is the H sign. So as time passes, the MS lesions leads to persistent residual T2 hyperintense lesion that is only mildly reduced from the acute lesion. In NMO, T2 lesions are markedly reduced in the size with mild reduced T2 hyperintense in most. In MOG, T2 lesions often resolve completely. In MOG, it resolves completely. In NMO, it is markedly reduced, but in MS, it is only mildly reduced. So this you must remember. So to summarize, in MS, there is a peripheral dorsal lateral column lesion. It's a short segment, a ring-like homogeneous. It could be patchy. In NMO, central gray and white matter, bright spotty sign you should remember in NMO. MOG you must remember is a conus, and the central H sign, long or short segment, multiple. This is single, this is multiple. Cervical or thoracic is common in both. So what is MRI optic nerve finding in MS, NMO, and MOG? We'll compare that. In MS, there is optic nerve enhancement. It is extending less than half of the length of the optic nerve. So less than half of the nerve, that is MS. Predilection for optic chiasma, that is NMO. Here, the chiasma. Here, the less than 0.5%. And here, it's MOG. It's a bilateral antioptic pathway extending more than half of the length.